Hello. In response to the survey questions, I was asked to review the common blood groups. So this video is going to be a very condensed review of the common blood groups. This is not a comprehensive review, so still make sure that you review your textbook material and any of the notes from the immunohematology section or clinical blood banking section. First, we will review the ABO blood group system. ABO antigens are either glycolipids or glycoproteins, depending on which carbohydrate is added. They're found on red blood cell membranes, lymphocytes, platelets, tissues, and bone marrow. They're developed in utero, and they develop around 5 to 6 weeks gestation. The most common frequencies found in Caucasian and African ethnicities are types O and type A, followed by type B and then type AB. The H antigen is needed for both A and B expression, and what's unique about the H antigen is that it contains fucose. The A antigen is denoted as N-acetogalactosamine, and the B antigen contains D-galactose. This slide shows the biochemical structures of the A, B, and H antigens. On the left, we have a red blood cell with the H antigen attached. The H antigen includes glucose, galactose, N-acetylglucosamine, galactose again, and then fucose. If we attach an N-acetylgalactosamine to this H antigen, we now have the A antigen. If we attach a galactose molecule, we now have the B antigen. Let's take a look at how A, B, and H antigens are inherited or not inherited. The H gene consists of two alleles, either big H, which is found in 99.99% of the population, or little h, which is very rare and is known as an amorph. An amorph is a gene that's unable to code for a functional protein, therefore there's no phenotypic expression. ABO genetics follows basic Mendelian inheritance, therefore we can use Punnett squares to predict genotype and phenotype. A and B antigens are inherited codominantly. This means that if both are inherited, they will both be expressed. Type O is an amorph allele. It is also recessive. If both little h alleles are inherited, this is what's called the Bombay phenotype, which is extremely rare. They will forward and reverse type as an O-type patient. They will form antibodies to the big H antigen, and we must transfuse autologous or use other Bombay phenotypic donors. Antibodies to the A and B antigens are of the IgM immunoglobulin class. They're capable of activating complement, and they react at room temperature. They cause strong direct agglutination. They're also known as isohemagglutinins. They're naturally occurring. This is usually due to exposure to either A or B-like antigens in the environment on bacterial membranes or pollen. And these antibodies develop at birth. They're usually detectable between 3 to 6 months of age. Back to that strong agglutination and activating complement, let's look at what intravascular hemolysis looks like. So on the right-hand side, we have red blood cells that have the A antigen on the outside of them. To the left of that, the snowflake-looking structure is the anti-A IgM pentamer. And then to the left of that, we have a complement protein. When these donor cells are introduced to, say, someone who produces an anti-A antibody like a type B patient, that anti-A IgM antibody will bind, causing agglutination of the red blood cells. And then the complement protein will bind to the CH portion, the complement binding site of that IgM antibody. This will activate the complement cascade, eventually causing the membrane attack complex to lyse the red blood cells and release hemoglobin. Remember, hemoglobin can be toxic to the kidneys, and subsequently other white blood cells are going to release cytokines, which will cause inflammation, fever, and chills. Let's take a quick look at the ABO subgroups. Of A, there's subgroups 1, which is found in 80% of the population, 2, which is found in 20% of the population, and then very rarely either A3, AX, EL, M, or Bantu. A subgroups can produce anti-A1. B subgroups are very rare. Dolichos biflorase is also known as anti-A1 lectin, and this will cause agglutination of A1 red blood cells. Ulex europaeus is an anti-H lectin. Anti-H lectin reacts with red blood cells that have more H antigen on them. This helps us identify discrepancies. Group O red blood cells and group A2 red blood cells have more H antigen on them than group A1 red blood cells. Anti-A, B reacts stronger with A subgroups than the typical anti-A1 reagent. We usually see ABO discrepancies in either reverse or forward typing or in both. In forward typing, we can see an extra antigen or a weak antigen, and examples of discrepancies found in forward typing are acquired B, where you have a B-like antigen that is caused from GI disease, polyagglutination, rouleau, ABO subgroups, non-type specific transfusion, marrow and stem cell transplant. Discrepancies found in reverse typing are usually caused by unexpected antibodies or a weak or missing antibody. Examples of these types of discrepancies are a subgroup of A with an anti-A1, a cold autoantibody, a cold alloantibody, rouleau, or age, either young or very old. Secretor status involves the ABO blood group, the Lewis blood group, and also the SE gene. The SE gene has two alleles, big SE and little se. Big SE are considered secretors, and they secrete A, B, and H antigens in saliva, urine, tears, bile, amniotic fluid, breast milk, exudate, digestive fluids. Pretty much any fluid you can think of, these A, B, and H antigens will be secreted. If the SE, big SE, and LE, Lewis, genes are inherited together, Lewis B will then be adsorbed onto the red blood cell, causing a homozygous Lewis B blood type. And we'll talk more about that when we review the Lewis blood group. Now let's take a look at the rhesus blood group, or Rh blood group. Rh antigen expression is controlled by two genes. The RhD gene, which controls D expression. Remember, D is synonymous with the Rh antigen. And RhCE, which controls the big C, little c, big E, and little e antigen expression. If individual antigens are being expressed, we usually express this in the Fisher-Race format. This is DCE. And if we are trying to denote haplotypes, we usually express this in the Wiener nomenclature. For big C, big D, little e haplotypes, this would be the capital R1, capital R1. And remember, the D antigen is the most immunogenic out of the Rh antigens. Now let's review weak D, or the mosaic D. Weak D must be detected by the indirect antiglobulin test or brought to the AHG phase of testing. There are three different causes for weak D or mosaic D. The first one is genetic, when we have a weak expression of the little c, D, and little e haplotype. We can also have a positional effect, which occurs when big C is inherited trans to the D antigen, or partial D when only part of the D antigen is inherited. Partial D is usually caused by decreased epitopes, so therefore they have decreased antigen antibody binding sites, and it's usually seen in Rh positive people who develop anti-D regardless of their Rh status. Weak D recipients are Rh positive, but we need to transfuse them with Rh negative red blood cells so that they don't develop the anti-D antibody. Unlike anti-A and anti-B antibodies, Rh antibodies are produced after exposure to Rh antigen, usually from a red blood cell transfusion or during pregnancy. Rh antibodies are IgG, They do not activate complement. They react at 37 degrees and in the AHG phase. Rh antibodies are also enhanced by Lys, PEG, or enzymes. Big C, big E, and little e can all show dosage, but the D antibody, anti-D antibody, does not show dosage. Rh antibodies are capable of causing hemolytic transfusion reactions and hemolytic disease of the fetus and newborn, because IgG immunoglobulins can cross the placenta due to their small size. Okay, now let's talk about the Lewis blood group system. Lewis antigens are not transcribed onto red blood cell membranes. They're produced by tissue cells and then secreted in fluids. These antigens are then adsorbed onto the red blood cell membrane. Because of this process, it may take up to 6 years to fully develop. Lewis antigens are enhanced by enzyme treatment, and usually red blood cells type as Lewis A and B heterozygously positive transiently during the first years of life and then gradually switch to the proper phenotype, either homozygous for A or homozygous for B, depending on which Lewis antigen is inherited. Lewis antigen inheritance is controlled by the LE or FUT3 gene and the SE gene that are both located on chromosome 19. If the LE gene is inherited, then Lewis A is absorbed onto the red blood cells, causing a Lewis A homozygous phenotype. Lewis A is the only antigen that can be secreted by a non-secretor. If the SE gene is inherited, then Lewis B will be adsorbed onto the red blood cells, causing a Lewis B positive homozygous phenotype. Lewis antibodies are IgM, therefore they react around 4 degrees Celsius. Sometimes they can react at 37 degrees Celsius, but we will see them react at room temperature, 37 degrees Celsius, and AHG phases in testing. Lewis antibodies are not clinically significant. We can neutralize these antibodies with plasma, serum, or saliva from people who secrete these substances. And Lewis antibodies sometimes form during pregnancy and then disappear after delivery. Now on to the MNS blood group system. The M and N antigens are antithetical pairs. They're associated with glycophorin A, and they're destroyed by enzymes. Usually, anti-N antigen is very rare, and the gene for both the M and N antigens is located on chromosome 4. M and N antibodies are IgM, so they react at 4 degrees Celsius or 37 degrees Celsius, and you can see them reacting in the immediate spin, 37 degrees Celsius, or the AHG phases of testing. They're not usually clinically significant unless a portion of the anti-M antibody is IgG. Then it would be clinically significant because it could cause hemolytic transfusion reactions or hemolytic disease of the fetus and newborn. M and N antibodies typically demonstrate dosage. Big S and little s antigens are antithetical pairs. Big S, little s, and U are antigens that are all associated with glycophorin B. We usually don't see the U antigen in antigrams, but it is associated with this blood group system. The gene for these 3 antigens is located on chromosome 4. Big S and little s antibodies are IgG. They react at both 37 degrees Celsius and AHG phases of testing, therefore they are clinically significant. Anti-big S, little s, and anti-U can cause hemolytic transfusion reactions and hemolytic disease of the fetus and newborn. Now let's look at the P1PK globocyte blood group. The P1PK gene is located on chromosome 22, whereas the globocyte gene is located on chromosome 3. These antigens are enhanced by enzymes. This blood group system is capable of eliciting several different antibody responses. The anti-P1 antibody is an IgM antibody and is capable of reacting at all phases of testing. It's not clinically significant and therefore we might want to remove it from patient plasma if we're trying to identify an alloantibody. We can neutralize this anti-P with hydatid cyst fluid, pigeon droppings, or turtle dove egg whites. Anti-P1P PK is an IgG antibody and is clinically significant. It is associated with spontaneous abortions, and it's usually found in people with a P phenotype, and therefore, since this is rare, we might need red blood cells from other P phenotype donors. Auto-anti-P is naturally occurring. It is responsible for causing paroxysmal cold hemoglobinuria, and the mechanism involved in this disease is this auto-anti-P will bind to the red blood cells in the cold weather, and then it will fix complement. After returning back to normal body temperature, that complement will activate the complement cascade and lyse the red blood cells. So these patients may need a blood warmer in order to transfuse red blood cells without causing hemolysis. Now we'll talk about the I blood group system. Big I and little I are not usually considered antithetical pairs. Big I and little I antigens are high prevalence antigens. In people who are less than 18 months of age, we see the little I antigen, and as they grow older, past 18 months of age, they start to form the big I antigen, except in the rare adult phenotype of little I. These I antigens are enhanced by enzymes. I antibodies are IgM. They react at 4 degrees Celsius, immediate spin, and occasionally at 37 degrees Celsius. They are not clinically significant, but can mask clinically significant antibodies. And again, we can neutralize these, and we neutralize anti-I antibody with breast milk. We might need to pre-warm the specimen or perform a cold autoadsorption, where we take the patient's own cells, because we know it has that I phenotype on it, and we remove those anti-I antibodies from the plasma for further investigation of other alloantibodies. A very strong reacting anti-big I is associated with mycoplasma pneumonia infections. The KEL blood group system. There are multiple clinically significant antigens found in the KEL blood group system. There is big K, typically referred to as just KEL, little k, sometimes referred to as Chelano. These are antithetical pairs. KPA and KPB, which are antithetical pairs. JSA, JSB, also antithetical pairs. And sometimes KU is referred to, although we will not see the KU antigen on any antigrams. Keep in mind, little k, KPB, and JSB are very high incidence antigens. All KEL antigens are very immunogenic. In the KEL null or KEL naught phenotype, the KEL antigens are not expressed, but the KX antigen is. The KX antigen is needed to express the other KEL antigens. And this phenotype usually has an increased amount of the KX antigen. In the McLeod phenotype, there is an allelic alteration of KX on the X chromosome. This phenotype lacks the KX antigens, and therefore we have a decreased expression of other KEL antigens. It causes a decrease in red blood cell survival due to abnormal function and morphology of the red blood cells. The XK gene codes for the KX antigen on the X chromosome, and the KEL gene is found on chromosome 7. KEL antigens are unaffected by enzymes, but destroyed by dithiothiotol. Remember, DTT is used to destroy the CD38 antigen on red blood cells in patients that are undergoing anti-CD38 therapy. This drug is also known as daratumumab, Darilex, or just Dara. Because DTT destroys both CD38 and KEL antigens, we must remember to transfuse with KEL-negative units. Anti-CD38 antibodies interfere with all indirect antiglobulin phases of testing. KEL antigens are IgG, and we usually see them reacting at 37 degrees Celsius or in the AHG phase of testing. They're very immunogenic. They cause very strong reactions, and they cause hemolytic transfusion reactions and hemolytic disease of the fetus and newborn. Now let's review the KID blood group system. The KID antigens are JKA, JKB, and JK3. JKA and B are antithetical pairs. KID antigens are enhanced by enzymes, and the gene is located on chromosome 18. KID antibodies are IgG, react at both 37 degrees and AHG. They are also capable of binding complement. KID antibodies commonly show dosage, and they can cause hemolytic transfusion reactions and hemolytic disease of the fetus and newborn. KID antibodies are notorious for deteriorating during storage, and the titer falls to undetectable limits in plasma, which commonly causes delayed hemolytic transfusion reactions when we don't detect the antibody. The Duffy blood group system. The Duffy antigens are encoded by 3 different alleles: Duffy A, Duffy B, and Duffy Y, which is the silent allele. Duffy A and B antigens are antithetical pairs, and the gene is located on chromosome 1. People who are Duffy A and B negative are more resistant to Plasmodium vivax. This is typically seen in the African American population. Duffy antigens are destroyed by enzymes. Duffy antibodies are IgG. They react at both 37 degrees Celsius and the AHG phases of testing. They're capable of causing hemolytic transfusion reactions and hemolytic disease of the fetus and newborn. Duffy antibodies commonly show dosage. The Lutheran blood group system. The Lutheran A and Lutheran B gene is found on chromosome 19. Lutheran A and Lutheran B are antithetical pairs. Enzyme treatment has variable effects on these antigens. There are 2 different immunoglobulin class antibodies to the Lutheran antigens. Lutheran A is an IgM antibody, reacts at room temperature, and can be naturally occurring, usually not clinically significant. However, Lewis B is an IgG antibody that reacts at 37 degrees and AHG phases of testing. It's rare, but it can cause hemolytic transfusion reactions and hemolytic disease of the fetus and newborn. We've reviewed the common blood groups. Now we're just going to quickly talk about some of the other blood groups that exist. Here is a list of the other blood group systems and their antigens. The high incidence antigens are in bold. Cheeto and Rogers are HTLA antigens, and they're neutralized by serum because it contains complement. The XG gene codes for the XGA antigen, which is the only sex-linked blood group antigen of clinical significance, and it has a higher incidence in females. The VEL antigen is very high incidence, and anti-VEL is clinically significant. And although the anti-SID antibody, anti-SDA, might not be clinically significant, sometimes it interferes with testing, so we may need to neutralize this antibody using urine. When looking at an antigram during testing, we usually see these other blood group typings under the special antigen typing section on the antigram. Here you can see Cobalt, York, and Diego antigens that are specially typed on this antigram. So now that we reviewed all the different blood group systems, I want to show you the different antigen characteristics written in a different format. So first, we'll look at the different immunoglobulin classes. IgM antibodies are the Lewis, P system, I system, M and N, Lutheran, and SID. IgG antibodies are always clinically significant because they're capable of causing hemolytic transfusion reactions and hemolytic disease of the fetus and newborn. They include the RH system, Kel, Duffy, KID, Lutheran B, SS and U, XGA, BG, and HTLA antigens, Cheeto, Rogers, York, JMH, etc. Let's take a look at antibodies that are capable of showing dosage. Remember, dosage is where you have weaker reactions when the red blood cell has the heterozygous form, and stronger reactions when that red blood cell has the homozygous form of a particular antigen. Antibodies that are capable of showing dosage include the KID blood group system, Duffy, Lutheran, the RH blood group system except for anti-D, and the MNS blood group system. Now we'll list the blood group antigens according to their population frequencies. High-frequency antigens are defined as antigens that are found in greater than 98% of the population, and it's usually harder to find compatible red blood cell units for these patients. They include little e, KPB, JSB, little k, Lutheran B, IHP, SID, ENA, and HTLA antigens. Low-frequency antigens are defined as antigens that are found in less than 2% of the population, and therefore it's much easier to find compatible red blood cells for these patients. They include KPA, JSA, Lutheran A, CW, VEL, and PK. Of these antigens that are listed, sometimes we cannot rule them out. If we cannot rule them out, we want to try to find at least a heterozygous cell to rule them out, when typically we use a homozygous cell to rule out an antibody. But if we cannot find them, sometimes these are considered not clinically significant. It's not that they are not actually clinically significant, it's just that they are low frequency, and therefore it's much easier and there's a lower probability of finding blood that's incompatible and much easier to find blood that is compatible. Let's take a look at how the antigens are affected by different enzyme treatments. Sometimes we use enzyme treatment when we're trying to identify a very difficult antibody, and we are confused on the specificity of this antibody. Antigens that are enhanced by enzymes include the KID blood group system, ABO, RH, Lewis, I, and P1. Enzymes destroy Duffy, MN, Cheeto, Rogers, JMH, and XGA. Sometimes it's easy to remember that Duffy destroys M and N. Antigens that are unaffected by enzyme treatment are both the Kell and Lutheran blood group systems, and there's variable effects on big S, little s, and YKA antigens. Neutralizing substances were already discussed for the other different blood group system review topics. Neutralization is used to remove antibodies that are interfering with testing so that we can look for other alloantibodies that are clinically significant. Here is a list of neutralizing substances for the different antibodies. Anti-P1 can be neutralized by hydatid, cyst fluid, pigeon droppings, and turtle dove egg whites. Anti-Lewis antibodies can be neutralized by plasma, serum, or saliva. Anti-Cheeto and Rogers HTLA antibodies can be neutralized by serum because it contains complement. Anti-SID antibodies can be neutralized by urine, and anti-Big I antibodies can be neutralized by human breast milk. That is all I have for you. I hope you found this review helpful. Please feel free to review this video as many times as you'd like before your ASCP exam.